And this is, as you can really see also, there are a lot of chromosomal abnormalities. Frankly, you can really try to describe all these abnormalities, which sometimes can be very difficult to encounter all of them. And frankly, this is why people don't like to do cytogenetics on lymphomas and solid tumors. This is not unusual here. Next slide. And we also run the RNA classification, and as you can see, this is classified as diffuse large B-cell lymphoma. And you can see that the I67 is extremely high. So, but MYC, as you can see it in the middle, is not significantly. So this is very high Ki67, but not high MYC. And of course, all the other markers are typical for B-cell or diffuse large B-cell lymphoma. Next slides. What's really interesting about this, and the reason is because of the deletion on the chromosome. So as you can see, this is a large deletion that lead to, and the fusion is between B1 and grafting. And the VAB is very important gene because it is NFA kappa P activation protein. And so the fact it is activated because of these deletions is very important. The reason I'm presenting this particular case, because frequently we see a fusion messenger RNA between two genes that are close to each other on the same chromosome. We usually don't report them because they could be because of alternative splicing and jumping from one gene to the other genes. But this is the distance between the two genes here is very significant. One is located at B12.3, the second one at B11.2. So the two genes are very far away, and this is really because of the deletion, and most likely this deletion is relevant because of the genes which are involved in this. The patient has MYD88 mutations, and MYD88 is almost always associated with ABC or non-GCP diffuse large B-cell lymphoma. Next slides. So this is the classifications, and again, this is similar to the first case. But it has very high KI messenger RNA, and it is also very aggressive disease. Dr. Leslie?
So this patient also has had a very aggressive course. So first diagnosed around age 60, 4 years ago, and actually had B symptoms and was found to have a cardiac mass that was diffuse large B-cell lymphoma, was treated elsewhere with R-CHOP for 6 cycles. Interestingly, on that baseline path report, it was non-GC, double expressing, though non-double hit, and had several extra copies of MYC, up to 9 in 6% of cells. So a year later, relapsed, had rice, transplant, again relapsed about 9 months after her autologous stem cell transplant, got Revlimid, ibrutinib, and rituximab, or the R2I regimen, achieved a complete response, had CAR T-cell therapy, then again, unfortunately progressed with the cardiac mass, B symptoms, and tried the Revlimid again, kind of based on the non-GC and the good response before. That patient unfortunately did not respond to Revlimid at that time point, or lenalidomide, I should say. And then got a CD20 bispecific T-cell engager, which had a complete response and then quickly relapsed. And at that time point, we checked this NGS, so an incredibly heavily pretreated patient, however, had a few potentially clinical trial options, is still in good shape. And actually, we have a study looking at an IRAK4 inhibitor that is first developed in patients with MYD88 abnormal lymphomas, but being looked at, all types of diffuse large B-cell lymphoma. So based on this profile, we actually screened her, and she was eligible to start that study and very interested in an oral IRAK4 inhibitor. Unfortunately, she progressed very quickly and did not maintain eligibility, so had to move on to a different treatment. So I don't know what her response is, but that was actually critical, at least at that time point, this NGS profile to help pick which way to go in this very heavily pretreated patient.
Great, thank you so much.